I've got
Yeah, no, I've got to get out, so yeah.
Good afternoon. Thank you for joining us for Dementia Matters Part 1 of 2. My name is Phoebe James, and I'm a Professional Development Officer with the Hunter New England and Central Coast Primary Health Network. Before we begin, I'd like to acknowledge the traditional custodians of the lands I live and work on. For me here in Newcastle, it's the Wabakal and Warramai land, and pay my respects to elders past, present, and any First Nations people joining us today.
So she's just gone, oh, I want to get back.
I just wanted to mention before we start that this session is being recorded. The recording will be available in the Education Library on the PHN website in the coming days.
So that was a huge stitch up for you.
And at the end of the webinar, I'll put a link in the chat box for an evaluation. If you could fill that out, that would be great because it does give us a lot of good information. If you have any questions for our presenters, please use the chat box function and they will get to them if we have the time. It's now my pleasure to introduce Professor Dimity Pond and Carolyn Gibson, and I will hand over to Carolyn now. Carolyn, you will be on mute, so just make sure you unmute yourself. Thank you.
Okay, can you hear me?
You can, thank you.
Good. Apologies to everyone. I've got camera problems, so I can't see me, but I can hear everyone and see others. Dimity, you can monitor the chat, can't you?
Yes,
yep,
yes,
good.
I've got it open. Yeah.
All right. So thank you everyone for coming along. It's great. So this talk we've called it Dementia Matters, and it really is geared towards the primary care nurse or the general practice nurse primarily on recognising what cognitive change might look like, when it might be a concern, how it impacts on the person, and then what can we do about it to better support the person living with the dementia and also the carer and the family, if there is one. Just to start off, if I'm having Teams meltdowns. So I just, we've done acknowledgements of country, but I'll just acknowledge the country I'm on today as Wadawurrung land. I'm in Ballarat in central Victoria. Don't worry about that one. So as I sort of very briefly said, we're looking at why does dementia matter? What are the key features and main characteristics of dementia? What might indicate potential change? How does this impact on a person? Because really that's the most important thing, particularly us as nurses. We're very interested on people being able to be as independent and lead as meaningful lives as possible. And also today we're also going to start looking at how to have a conversation about cognition, because it's all very well if we recognise a change and everything, but if we don't have the confidence to be able to explore that a bit more deeply, then it's kind of a bit of a barrier. And then in the second session, which is next week, we're going to do a more practical approach. We're going to look at how we can take the changes and understand how they impact, and then what sort of strategies can we put in place to support the person. And also when it's in the context of other chronic diseases, because generally speaking, people living with dementia will have 4 and plus other chronic diseases. And a topic we'll touch on, because we've been asked about it before, is that idea of looking after yourself as well. Because looking after people with dementia, whether it's in aged care, primary care, hospital, it can be challenging both for yourself and the patient and the family. And so it's important to reflect and think about what it is you're doing. And part of self-care, I think, really is about us working together as a team, particularly in primary care, and also attending education sessions such as this one, because I think having a bit of knowledge really does help us. Now, DTA do have a little pre-evaluation. I think it's just 3 questions. So if people could just take a sec to scan that and answer the 3 questions, that'd be great.
Caroline, can I interrupt while people are doing
yes,
that?
Yes, please, give scanning time.
So as the GP, so I'm a practicing GP at Barara on the outskirts of Sydney. So I just wanted to say how important I think this is, because I don't think GPs can do it alone. when it comes to dementia and cognitive impairment. I think we need to work as a team with our GP nurses and the other primary care professionals that the person might see, because we have a limited ability to identify cognitive impairment when someone's just sitting in our, at our desk saying, I need just some repeat scripts and a referral to the dermatologist or something, or a care plan or something. And it's a fairly structured conversation and we don't delve into things. So, of course, there are cues, but I think the GP practice nurse is in an ideal position to identify that there may be problems. And in this, we're not trying to turn you into people who diagnose dementia, which is a very tricky thing, and GPs don't necessarily want to do that either. But we do want, I think Carolina will agree with me, we do want you to identify if a person is struggling with their thinking and memory and can't take in everything that you're telling them about their medications, about their wound dressings, about side effects from their vaccination you've just given them, and when they should come back and be seen again. All those things you might need to make adjustments for, as Caroline said, with your chronic disease management that a lot of you will be doing from now on with the changes in the care planning. So I think this is really important and timely for you guys to be here. Okay.
I think that's a good point, Dimity. I think I rushed ahead a little bit because I was so flustered at spending half an hour trying to get a camera working that didn't. I didn't really explain too. So yeah, Dimity's a GP and someone I work with, and I'm actually a registered nurse, and I've worked in general practice as a general practice nurse. I've also worked in the community in district nursing, and also in Victoria we have the HARP program, the Hospital Admission Risk Program, which works with people with complex comorbidities that present to hospital frequently. And so I've got more that primary community care nurse experience. But I was really interested when I was sitting at people's kitchen tables and they had either newly diagnosed dementia, undiagnosed dementia, or diagnosed a long time in the past, that people were really confused and overwhelmed and were saying things like, oh, but our GP doesn't listen to us, or they say it's just old age, or they don't talk to me, they talk to, the other person all the time. And there was a real level of frustration, and I thought, surely we can do this better. And so that's how I sort of got involved in this area from a nursing perspective and what we could do. And of course, it needs to be team-based. So we do need to, and that's why we have Dimity to bring us a different perspective. But we do need to work together in primary care. And that doesn't always necessarily work very well with different practices. It's a challenging area, but it is something that we need to work on and achieve in order to deliver the best possible care, and for each of us to use our skills and knowledge to the best of their ability, because our skills and knowledge complement that of a doctor, and both are needed. And in dementia care particularly, there's a lot of psychosocial aspects to the care, not medical, because it can't be cured. The medications around it are, I'd say, a bit hit work for some people in slowing the progression, not for others. But where people really notice the loss is around sense of identity and the ability to participate meaningfully in society, to still feel like their life has value and meaning. And that shift away from the idea that once you get told you've got dementia, it's a death sentence and it's all over and you're now a shell of your former self. We have to reframe that into thinking positively about, it's not a great disease to get, but what can we do to best support this person? And we can do something. And that's really what this session is about. So moving on. Dimity mentioned the new chronic conditions, GP chronic conditions management plan. It's not chronic disease. And this is just to highlight one of the big barriers that we come up across a lot when talking about dementia care in general practice is that it's not financially viable because it takes time. And it's true, it does take time, but you don't need to do everything at once. And there are MBS funded opportunities in which we can do things. So I've just put that up front just to keep in mind that I don't think funding opportunities are necessarily a barrier if we can still make better use of what we do have. And the new chronic condition management plan, you can do 3 monthly, and it brings in more money than just doing the old version of a new one and then a 6-month review. And the other thing too, when Dimity mentioned about how it's becoming more and more important to know more about dementia, is, I think, didn't you say, Dimity, it's just become the leading cause of death in Australia?
Absolutely. They
That
announced
was
that
just
this week.
this week. And I always find it remarkable that so many people shy away from looking and recognising dementia and then opening up those conversations. But we wouldn't do it with heart disease or diabetes or asthma. You know, if someone was obviously struggling, we'd ask questions and that. And yet dementia just seems to still be under the covers a little bit and no one really wants to go there. And I think it's only by us having these conversations and maybe taking a bit of risk, but framing it positively that, yeah, we'll start to get somewhere. But let's get moving and see what you think. So, why does it matter? Well, as we just said, it's now the leading cause of death in Australia for men and women. So it's taken over cardiovascular disease. It affects a lot of people. And I think one of the things to think about is in the role of primary care, it's about keeping people out of hospital. And people that are living with dementia, if they do end up in hospital, they have 5 times longer hospital stays than someone without dementia. And that's really important because someone with dementia in hospital does not do well. And they never come home and bounce back as well. They just steadily will decline. Particularly, they're more at risk of a delirium, of a fall, you know, in other infections, all sorts of things. And so I think if we're doing our job properly, we really want to focus on keeping people out. And the other thing too is a lot of assumptions are made that people living with dementia are most probably in nursing homes, but 2/3 of the people living with dementia in Australia are in the community. So they're going to be coming in and out of your front door. You are seeing these people all the time. You just might not know it. I've sort of said this too, that people living with dementia have comorbidities. Carers of people living with dementia have high levels of stress, depression and other comorbidities compared to people who care for people without dementia. And as I said, with an ageing population, with the encouragement for people to age at home and live longer in the community, this and the fact it is now the leading cause of death, it has become more and more critical that we know something about it.
I'll just throw in there, Caroline, about the carer. I've taken to always asking the person living with dementia if their carer can come in to the consult with me. Sometimes they're a bit miffed, but usually not. Usually they're very happy to do that. And part of that, of course, is because sometimes the carer can tell me things that, you know, that the person might not like to talk about or might not remember, like a fall that they had or when they got lost in the shopping centre or something. And that's important information about, you know, how their dementia is progressing. But the other thing is that I use that opportunity to ask the carer how they're going. And I think it's really important for them to be able to just voice their concerns about their life. And I think it's really important to suggest to a carer that they might need respite and suggest the carer's gateway, which is Caroline will talk about later, where they can talk to someone and work out how to organise that. So the carer is vital in keeping the person with dementia going. Of course, they don't always have a family carer living with them or able to visit. And I actually do like to talk to the professional carers if they've got someone coming in who's driven them down to the surgery to see me. I say, you come in. And they go, oh, me? Do you want me? Why do you want me? I'm just, the driver and, I do a bit of cleaning. I go, yeah, okay, yeah. And how's the cleaning going? Oh, well, that's fine. And food, does she eat? Oh, well, yes. Well, actually, yes, I do actually help her a bit with that, And then I start to get a picture, which the person with dementia won't be able to tell me. So a carer, either a family carer or a professional carer is vital for you to understand. And you could do that with your care plan reviews. I think would be good. Okay, I'll hand back to Caroline. Sorry, Carol.
That's all right. We sort of jump between each other because we usually do this in person. I think there's a few interesting points there, and we will talk a bit about carers, but there's a couple of things that Dimity sort of brought up there. One is respecting the person living with dementia and getting permission from them to include the carer. But we can ask it in such a way that I tend to introduce that as, because you want their permission. And I sort of introduce it as in always, oh, look, we work as a team. You've got some of your team here. It'll be great if we could get everyone's perspective. It doesn't mean anyone's particularly right or wrong. And also, it just means that we can get a better picture and therefore know how to help you better to achieve the things you want to achieve. So I try and set it in a context of why it's a positive thing, because you most probably have all experienced if someone with a cognitive change comes in and the carer's there, like the husband or the wife, they'll already be on the back foot saying, I don't understand why they're here. I'm not lying. They seem to, imply that I'm lying, etc., etc. So you just want to bring the heat out of that straight away. And the other thing too around the idea of a person in dementia and the importance of a collateral history is also the idea that when we talk about care of someone with dementia, we talk about care of a dyad, which means it's care of the person with dementia and the carer, and as the informal, the unpaid carer. So if there are the two, then we talk about we care for the both, the dyad. And because without the carer and the carer being kept well and healthy and able to care, then the person that has the dementia will decline. But we'll pick up on some of those points as we go through. Now, when we talk about bringing up the conversation about potential dementia or cognitive impairment, I'm not saying as nurses we would bring up the word dementia because it tends to be used as a diagnosis, even though we'll talk about in a second it's actually not a diagnosis. We don't tend to bring those things up, but we can bring up cognitive change and we can bring it up like I tend to use the words memory and thinking. Have you noticed any changes in your memory or thinking? But I'm going to talk more about how you bring up the conversation. But a lot of people have made the assumptions in the past that, or health professionals, that people don't want to know if they have dementia. But actually, sure, some people don't, but there is a lot of people out there that do want to know. And research has shown that if people have adequate support, then they can manage the disclosure of this sort of diagnosis, and the negative reactions can be outweighed by the way you approach, well, how are we going to support you now? And so people want to know, but at the same time, in knowing, you need to be providing the support and the follow-up, which is what we're talking about today. So why do I think nurses are so important? Well, I think we've just got the right relationships. We're in the right place. People talk to us. People say they can trust us. You will often know, I'm sure all of you, that when the person comes in to talk to you, they said, oh, I didn't tell the doctor that, they were too busy, or they don't have time, or they assume you do have buckets of time. But we just have, I think, different relationships, different expectations put on us. I think patients just see us differently, and they can disclose things that they're a bit uncertain about or are just not sure. And they sort of feel that they will get that more gentle support We can also, because while we're doing treatment room things or health assessments or chronic disease management planning, and if we've known the person over a period of time, we might then be able to pick up changes that the doctor might not pick up. And then we can let the doctor know, and hopefully that'll start triggering an assessment, a proper cognitive assessment to see, is there something going on that we should be concerned about? So I'm going to hand over to Dimity now on about what is dementia, the nuts and bolts of it. So Dimity, you'll just have to indicate when you want a slide to go.
Okay. So key features. So that word cognitive is not, I must say, it's not a word we use every day. So, but that means memory and thinking. And I like the words memory and thinking better, actually. So the memory and thinking changes must interfere with the person's ability to complete their usual daily tasks for it to be called dementia. All right. Now, there's a long lead up to crossing that boundary where, for example, people might be able to write themselves notes and so on and remind themselves and sort of compensate because they're forgetting things. So, and we'll talk a bit more about that later. But to be diagnosed with dementia, it needs to be interfering with daily tasks. And another thing is that it should not be attributable to other causes. And in particular, the ones that are common, the other causes, are medications that are slightly bombing people out so they can't think clearly. And that can be readily fixed by changing the medications. And that's something the GP or a pharmacy review might be able to help with, especially anticholinergic medications, especially the ones for urinary incontinence, are commonly at fault there. And people can get much brighter and more able to cope if they're changed to a less anticholinergic one. Other things are if the person has depression, you know, the emotional disease, depression, and they're feeling down and all the time, and maybe they're thinking about their memory loss, thinking this is towards the end and what was the point of it all and so on, and getting into a bit of a spiral there. And the depression in itself will stop them thinking. So that's another possible cause. And then the other thing is they may have something wrong with them physically, what we call delirium. We usually think about that as with a temperature, but you can have a delirium not with a high fever, but because you've got your blood sugars out of whack or your electrolytes out of whack or something like that. So I always think of the drugs, dementia, depression and delirium, the 4 Ds, when I'm looking at someone with cognitive change. And the other thing with dementia is it's progressive. It's not a normal part of aging. And we need to remember that younger people can have it as well. We might move on, Caroline. So what causes it? Well, there's a variety of diseases that damage the brain cells. And when I'm doing this face-to-face, I use my hands a bit. So I'll just use them a little bit here. You can see that cell body in the middle there, with the gold bit in the middle. That is the cell, a brain cell, all right. And that brain cell may deteriorate and stop looking as pretty as that and become like a blob when people have dementia. And that cell body's got amyloid in it, if some of you might have heard of that, and if you look under the microscope with a certain stain, it will stain up and you can see all these pink blobs in the person's brain. And of course, your brain doesn't function very well with pink blobs in it. And then you can see the neurons going out from that brain cell. They're connecting with all sorts of other neurons in the brain. And the other thing that happens with dementia is that those connecting neurons also start to be destroyed, and they release another protein, not amyloid, but tau, which you may hear about. There's a new blood test for that around, and it's being trialled in Newcastle, actually. Some of you may be aware of that trial. The blood test is checking, it gets into the bloodstream, and so you can see that the person's got dementia from the blood test. So those two things mean that those filaments are no longer connecting with each other. They're just a mess in there. And no wonder people can't remember things, or can't get words out, or can't appreciate what's going on, because the lines, the connection lines are gone. So we might move on. Thanks, Caroline.
Apologies.
Say again.
Apologies.
Oh,
Sleep at
right.
the desk.
No problem. So those changes happen in different people in different parts of the brain. So eventually they do tend to spread throughout, but they may start in completely different parts. So can you see that arrow, Caroline? No. I'm doing an arrow from my computer, but you probably can't see it. Yeah.
Doesn't come
So
online.
I can see your arrow. Can you point to the visual section there? Hopefully the audience will be able to see that too.
Yeah.
Yeah. So that green bit.
Simple.
So I had a patient who was perfectly okay with her memory and thinking as far as she was aware. But when she went for an eye check for her spectacles, the optometrist picked that she was missing a section of her vision. And that was not because there was anything wrong with the eye. It was because she had the beginning of those pink blobs and the tau protein all happening in that green part at the back of her brain there, in the visual cortex. And eventually it spread, and she's now got a typical Alzheimer's disease with quite marked thinking and memory problems. But it's all started with visual interpretation. So other people will get another sort called frontotemporal dementia, which is the big blue section at the front there. And they may have personality changes. They get very flat. They may be quite aggressive, and they have trouble with problem solving, and their family's just over it. Their family just thinks, I can't stand this anymore. And they may be okay with, they may be able to do a cognitive function test to get full marks, but they've definitely got something wrong with them. And that something is a form of dementia. So there's other ones there, I won't go through them all, but so there's different ones for different people. And so these different forms of dementia are called different things. So there's Alzheimer's disease, which I've described to you as pink blobs and tau protein. That's classic Alzheimer's disease. There's vascular dementia, where the blood vessels going to the brain get clogged up, and that bit of brain actually dies. And that's a vascular sort of dementia. That's less common than Alzheimer's, but very common in our population, especially people who've had problems with their blood vessels, like high blood pressure or cholesterol and diabetes affecting their blood vessels and so on. And then there's the frontotemporal, which I just described to you. There's Lewy body, which is a bit like Parkinson's disease often, and it may go with Parkinson's disease, and it causes a particular pattern, which we'll talk about later too. And then there's about 200 other sorts that are 5% of dementia cases, and I don't know them all either, so don't feel alone. And what about the cognitive assessment tools? Many of you will know the mini mental state exam, the MMSE, or the MOCA, and they're both very usually used in general practice. There are others as well. There's a clock drawing test, which I quite like, which is very quick. But we need to be aware that if someone scores badly on those, it doesn't mean they've got dementia. It's only a screening test. So it might be that they've got one of those other 3 Ds. They've got depression, or they've got delirium, or they're on a medication, a drug, which is upsetting their thinking and making them answer that poorly, or they may not be able to hear you properly, or see the thing that you've asked them to copy. So there's various reasons why those tests are limited, but they are a useful screening, give us a bit of an idea of what's going on. And it's particularly useful if you're doing it as the GP practice nurse. You're doing that annually as part of the 75 plus health assessment, and you notice that, say on their mini mentor, they started off at 30 3 years ago, and then they went down to 28 2 years ago, and then a year ago they're on 26, and now this year they're on 25. Those are all normal scores, but they are going down, and that is a big red flag for cognitive problems. So the tests are useful, but they're an adjunct. They don't replace you listening and watching what's going on. Okay. I think you do this one, don't you, Carol?
It's up to me, yes. I was just thinking, I was going to add something when I was doing that. I can't remember what it was. Is there anything in the chat, Dimity?
No, there isn't anything.
If anyone has little questions as you go along or anything or wants clarification, just pop it in the chat and I'll get Dimity to keep an eye on it for us. So Dimity sort of explained the different types of dementia, and that's all very well, nice academic, but sometimes it's useful for us also to see, like visualize, when a person comes in, what might a person look like or act like with one of these types of dementias. Now, remember, this is fairly crude because they all overlap, everyone's different, everyone progresses at different stages, but it's just to give you a little sense of people. So here we've got Alice. Now, she's forgetting things as soon as she's told them. Get this out of the way. She's frustrated and anxious. She's having difficulty finding the right words. Now, that's called aphasia. She doesn't recognise familiar people. That's called agnosia. And her daughter says the changes have been gradual and getting worse over time. Now, this is a typical, why doesn't that pop up? Hang on. There we go. Typical Alzheimer's type picture, particularly the rapid forgetting and the anxiety. You'll really find people with early Alzheimer's will show that because they're sort of aware there's something not wrong. They know they're forgetting things. They're frustrated because they're not able to do things the way they used to, and they're worried. And it happens gradually and it's progressive. Then we've got Mary here. Now, Mary, she's walking slower. Her initiative isn't so good. So that get up and go, starting off a task. And she's got some problems with consonants. Her mood's a bit low. She doesn't register, but her memory's not bad. Now, the difference in those, in the MMSE, for example, where you're looking at registration is when you say the three words, say apple, ball, penny, and you get them to say them immediately after you, that's registration. So that's where it's getting laid down, okay? Memory is later when you say, can you tell me those three words I told you, several minutes ago? That's memory. So her memory's actually not too bad, but she doesn't register things in the first place. She's not laying it down. And she seems to be worse after each hospitalisation. This is more a vascular dementia picture. Then we've got James. Now, he shuffles. He has disturbed nights. He has bad dreams. He's restless. He's up and down. He's often getting hallucinations, but they're not always distressing. And he has difficulty with his hands, with manipulating things, apraxia. And some days he actually seems quite good. And this is more of your Lewy body picture. The shuffling gait, the changes in gait and hallucinations, the restless nights, they're big red flags for Lewy body and Parkinson's.
Can I just say something there,
Yeah.
Caroline? The hallucinations can distress the carer, and they don't like to mention it. So if I have someone like James, or I have a carer in with me who's talking, maybe not in front of James, but and saying, he had Parkinson's and now he's got this. sort of dementia. They said it's actually dementia. And I say, oh yeah, and he's, you know, he's struggling with food and so on. And I say, has he had falls? Oh yeah, he's really off balance. And I say, and what about hallucinations? And they go, oh yes. Oh, is that part of it? He was telling me the other day that the whole of the Woolworths aisle was out in the out in the hallway, and we could go and get some shopping. He could see it through the door, he said. So so she was actually relieved to know that that was a symptom of this, and just to get it off her chest, to be aware that that can happen. Okay, back to you.
I think that's a really good point. So one of the things I've known, I've looked after a few people with Lewy body dementia with hallucinations and delusions, but more as hallucinations at home. And often the way I get to it is kind of know if you can see someone's got a diagnosis of Lewy body, for example, you're going to know that you want to be alert to what is their mobility like. Are they having falls? What is their sleep quality like? Are they having hallucinations? So, and difficulty manipulating buttons, cutlery, because, and this is what we're talking about later, it'll give you clues as to what functional changes there might be, quality of life changes there might be, and help you direct your questions. So with James, like Dimity said, I'd be asking about falls off the back of that diagnosis, but you would have seen that as well. That's something you would have seen the person walking into the room with. I'll ask about sleep quality, and then the way I might get to asking about hallucinations is if a carer will often volunteer, oh, they're up and down all night because I'm not getting any sleep, or just the frustration of that. And then you can ask, what is getting them up at night? What might be happening? He's seeing things, or sometimes, and you'll be interested in that, and it's that tell me more. And I think one thing that's important with hallucinations is often they're not distressing to the person, but yes, they can be distressing because they're not real to the carer or the other person, because they're like, well, it's not true. Why are they there? Let's stop it. But some people can actually find them quite comforting. And so, you know, it might be children. It's often children. I had one woman who the children used to come and join her for afternoon tea, and so the daughter had to set out extra cups and things for the children. And so it was like to the daughter, you don't have to correct that behaviour as such or change it. It's okay. Just go with it, because this is actually comforting the other person. And it doesn't really, you know, matter to you. It's just going to cause stress and anxiety and all these other problems if you try and say, no, that's not true. So this is where it all sort of starts to link together. If you've got a feel for the diagnosis, you understand what some of the key features of the diagnosis might be, you then can check in with this particular person if it's things for them. And then you can start drilling down to, okay, what's problematic and we need to look at, and what's okay. And we learn to just cope with and manage and keep an eye on. A lot of times Lewy body dementia people of the generation I used to work with, and the wife would cook the Sunday roast or the cooked meat and veg every evening. And this gentleman stopped eating properly and he couldn't handle the cutlery. And it took an awful lot of work with her to say it is okay to give him simpler food. It doesn't have to be the cooked steak and vegetables, because that to her was not being a good wife and not being a good carer. But he could not manage it. And we had to eventually progress to finger food, which horrified her, but it meant that he could manage it. He could feed himself and he could get adequate nutrition. Whereas continuing down the path of the meat and veg and eating cutlery, he couldn't do. But we've got some other bits on that too. Now, around the differentials, for example, we've got Clive. So he's saying, I don't know to most questions. He's not engaging in usual activities, short and poor long-term memory. That's more your depression type picture. And I haven't done delirium or anything like that. I'm just going to start talking about brain health promotion, then pass on to Dimity about risks. One of the primary roles in primary care is health promotion. We talk about cardiac, heart health, lung health, brain health, vaccinations, preventative medicine, all that sort of thing. And brain health is really something that needs to be talked about. And I think that's really a role of that we can have as nurses in our day-to-day conversations with people. So I'll pass over to Dimity to look at what some of the risk factors are. We don't have that long, Dimity, because we talk too much.
We talk too much. Okay. Well, you can have a look at a whole range of risk factors there. So there's various ways to use this. One is you can see down on the second line, you can see smoking, and you can see high blood pressure, and you can see obesity, and you can see excess alcohol. Well, if you tell someone they should stop smoking, they'll go, oh, yeah, everyone says that. But if you say you're more likely to get dementia if you keep on smoking, they listen. Same with the high blood pressure, same with the obesity. It is magic to tell someone that this is a risk factor for dementia. They've discovered this. And same with the alcohol. And if you can even get it down, that's great. But happy to give you a referral if you'd like, or mention it to the doctor. So that's one way. The other thing is, if you know that someone's had high blood pressure all their lives or has diabetes and they're getting older and they're not appearing to remember things quite as well, you know that's a risk factor. And so you might start assessing them using your cognitive function test and asking a few questions. You have your spider sensors out to saying this person is at risk. I need to really think about this possibility. That's enough, isn't it, Caroline?
Yeah, and I think it's really important when we're thinking about health promotion and cognition is that these changes start impacting at midlife. So even though people often won't start thinking about dementia till they're quite a bit older, you're laying down the changes in midlife, which to me is fairly scary. But given I'm past, most probably on the upper end of that or something, I don't know now. Keeps changing what we consider midlife to be. And that's where I say the 45 to 49, it's not the perfect bracket, but it'd be nice if it was to 55. But it is an opportunity that we can use, that when we talk about heart health, we could also talk about brain health, because really the factors are the same. Good, pretty much the same, except protect your head maybe, hearing and vision, a couple different. Yeah, I'll just do this bit, Dimity, then. Yeah. So the other ones are all heart health, but the protect your head and avoid injury is becoming more and more around, especially with athletes and head injuries, head protection. There's a lot of evidence there now about causing dementia. Staying social has been shown to have a real impact on cognition, and hearing and vision. So making sure people get their eyes checked, get their hearing checked, and wear the aids and wear any aids that they need. So recognising a change in cognition, again, this is what I've said is one of the steps that we can do. So first off, we can promote good brain health from midlife. Second off, if there is a change, one of our roles as nurses can be to recognise that change. I'm not doing that one. I'm doing that one. So I've got a little video here, and here it goes.
I'm a general practice nurse, so I'm pretty busy. Multitasking, helping, caring, counselling, answering questions, mediating, scheduling, listening, translating, assessing, assisting, observing, educating. Dozens of patients, each and every day. Nice to see you again, Mr. Bird. Let me take you through and we can see how that wound is healing.
Hello, dear. Nice to meet you. What's your name?
It's Sarah, Mr. Bird. I'm the nurse. How's that wound coming along? I'm in a unique position to see the changes in patients. To ask questions, I can notice early cues that may indicate dementia.
Was I supposed to bring my medication?
No, Mr. Bird, we're looking at your wound on your cheek today.
That's right.
Mr. Bird, remember we spoke about keeping your wound covered and dry?
Of course.
What I see, what I notice, what I do can make a real difference. You seem a little distracted today. Do you feel your memory and thinking has changed?
I do feel a little more forgetful. It is just old age.
I think we'll mention it to your doctor. Is that okay? Doctor, Mr. Bird appears to be having trouble managing his wound. I think a referral to district nursing would be useful. He also feels he's been getting more forgetful. I would like to get him back for a 75 plus health assessment and a cognition test to check his memory and thinking.
Good idea, thanks. Mr. Bird, I will see you in a week or so after you have your appointment with Sarah.
There's so much we can do for patients using our nursing knowledge, skills and experience. Being alert to changes in memory, thinking or behaviours is an opportunity to identify possible dementia and provide patients with the right care and support to live well. How are you getting home, Mr. Bird?
I think my daughter is coming to pick me up.
I can talk to her about what we've discussed with the doctor if you like. And I've written down the details for your next appointment. Let's ask your daughter if she can come with you.
Thank you.
General practice nurses are uniquely placed to notice changes that may indicate dementia, act early and make a difference.
So the idea behind that little video was just to illustrate that, yeah, we're all really busy in our practice. But when we see people, if we notice they're doing something differently or they look differently or something, it's just to think why. And that's sort of what that nurse is doing. And then what are some possible things you could do as a result of it, like talk to the carer or the daughter in this case, write down when the next appointment is, do maybe a 75 plus health assessment because that provides you with a structured opportunity to maybe do an MMSE and clock drawing test. So it just gives you a little bit more idea of what we're going into now. So Dimity, I don't know if you want to go over what some of the common signs and symptoms are, and then I'll go into how we might sort of get some of this information when talking to people.
Now, I'm going to be antsy, Caroline, and say something else.
Don't go for it.
What I really love about that video is the way the nurse didn't just pass it over to the GP or go, oh God, another thing to worry about, but suggested a solution, which was, can I book him in for a 75 plus health assessment, a cognitive function test? And so this is something that would be totally acceptable to the GP. And the nurse has just thought ahead and thought, what will work in this communication with the GP? I'm taking the responsibility. I can suggest this. As long as it's okay with them, I will do it. So I really like that. So we've got those signs and symptoms there. And a common thing in practice is that people forget their appointments, or they turn up late, or they're sort of unrealistic, or for the GP, they clearly haven't been taking their medications because they've all run out several months ago. So all of those things. But if you can think back to what people look like, those personas, and get a bit of a feel for it, that sort of slightly anxious, slightly uncertain, what am I doing kind of look, that is also a flag, a sign or a symptom. Okay, I'll move on, Caroline.
You might see, and I think all of you will relate to this, you might see it when someone comes in and they're always looking to the other person to answer.
Oh, yeah.
Or to check in with. And often when that happens, that's one of those sort of alerts thinking, why are they doing that? Because it'll be, they won't be sure of the answer or be worried about answering incorrectly or something. And so the other person will speak for them. Or alternatively, the other person overrides them. So they're trying to answer, but the other person has taken over that role already and answering on their behalf. And so there'll be all these sorts of little things that you'll notice and you'll think, hold on, just think why might that be happening? Is it an issue with cognition? And remember, you're looking for change. Some people you say, oh, do you forget people's names? And if they say yes, that's meaningless if they've always been someone who's bad on names. You want to know if someone was really good at something and now they're not, the change, and progressive over time. So asking questions and trying to get more information, some people can find quite challenging because it can be a confronting conversation, particularly if the word dementia gets popped in there by anyone. And there is a lot of social stigma. Hopefully it is slowly getting better, but there is still a lot of stigma about dementia and a lot of assumptions too that people are worried that if they do have dementia, they're going to end up in a nursing home before they can blink. You know, they're at the top of that slippery slope, that they're going to lose the ability, or basically feel they're going to lose themselves, the ability to function. And they will have all seen, like everyone will have seen really bad stories and people that have had dementia and what's happened. And so the best thing I can think of is that we need to frame these conversations in a positive light. What can we do that's positive? By not ignoring the negative, but reframing our conversations. First off, we want to set people up for success, though. So when you're doing and you've noticed a few times both of us have said cognitive test. That is one thing not to do. We use cognitive assessment. I did it in the video as well. Because again, when you're setting up saying I'm going to do a cognitive test, you're testing someone that can have negative implications for all sorts of reasons. So anyway, quiet environment. Make sure they got their hearing aids and glasses. Get their attention, keep their attention. So you need to talk directly with the person. You need to try and remove the clutter of the carer, as I sometimes think about it. Set up the environment that's, like I said before, about permissioning to have the carer included, but also setting up, I like to think of, I don't like stressful situations. I like to set it up initially to try and avoid that. And you can find, you most probably all had the thing where you've ended up with someone with the cognitive changes and the carer almost arguing in front of you. I prefer that not to happen. So I set it up that, okay, we're both going to work, we're all going to work together here. We're going to work out, we're all going to have a different say. It doesn't matter if we disagree, and we're all going to have the opportunity to speak without interrupting each other. I'll sort of set it up depending on, the personalities a little bit so that there's an expectation that everyone gets to say their bit without judgment. And you need to speak. Yeah, sorry. Yep.
I'll just say that an audiologist has just unmasked themselves in the chat and wants copies of the slides for colleagues. And I just said how important it is, the audiologist, because the hearing is so important for people with dementia.
It's amazing. Yeah. And because the hearing one's pretty new, was a new one with the Lancet Commission on that risk thing and the vision. And I was trying to work out why with a geriatrician friend that we both know, and why it is that it's got such a huge impact on the cognitive pathways. And it's got something to do apparently with the volume of pathways that go with vision, the volume of neural pathways. And so if there's a deficit in hearing, I can't work out all the pathophysiology of it. So maybe an audiology person can go and do that and report back. Because I think it's fascinating how the brain works and neural pathways and rewiring and all that sort of thing. But I think the audiologists and optometrists, ophthalmologists are going to have more and more of a role in needing to know about dementia and understanding what the changes are and the impact, because they might well see things before we see them as a functional change.
And I always say, in my simple GP way, if you don't use it, you'll lose it.
Yeah.
So if they're not hearing, if they've got wax or their hearing aids aren't working.
Yeah. If someone can't hear and ask you to repeat the question, check the ears.
Yes.
It's amazing how that doesn't happen. You get a complaint, we're always having to say the same thing. They've got dementia, da-di-da-di-da. You look in their ears and they're full of wax.
Yeah.
Of course they can't hear you and asking what the same question
is. And then if they're not using those pathways, then they'll lose the ability to hear, even if you get rid of the wax. So it needs to be fixed.
So, yeah, it's really interesting, but it's not something I need to delve more into it because it's like all that neuroplasticity research. But going back to the person who was asking about that, the audiologist, is if you go back to the reference with the risk factors, the Lancet Commission, within that, I think it has some leads and references around the hearing as a risk factor from memory, because it was a whole journal edition. Okay. So asking people, so first of all, as I said, you're setting themselves up for success. They have their hearing aids in, they can hear you. Hopefully they work. I'm going to sneeze. No, the cat just sat on me. Then I ask, I avoid, using the word dementia and all that. It doesn't matter, even if it's been diagnosed. I ask people, have you noticed any issues with your memory and thinking? Even though we've already established when we looked at those past scenarios, it is more to it than memory and thinking. But it is a start. And then I might ask questions like, are you finding it trickier to do some things you used to? And I'll try and frame things so they're non-threatening. So it might be, especially as we've known people over a period of time usually, you might know that they used to go to church every Sunday, or they're a knitter, or they were a keen baker. And it might be things like that you pick up the changes. So you want to know why. Like some people used to always cook quite complex meals. Now they're cooking tea and toast. Why? And so you can sort of say a lot. I've met a few people that have found that, and it's because, they were finding it more and more difficult to operate the oven. Is that something you experience? And you can start to clarify what's going on and probe. And then when I said about keeping it positive, I say it's good that we've talked about this because now we can figure out what's going on and there are things we can do to better support you. And so it's all this, we might be talking about things that are frustrating, sad, scary, etc., but it's a good thing. So let's talk about them because then we can work out what we can do. The last little section. And so put your questions in. I'm just going to go through, I'm just checking on my phone what ones I've got left because there's one section I've left in because you'll get the slides. So we've talked about what types of dementia there are, how dementia is a brain disease and how it affects the neural pathways, stops the communication. It looks different for everybody because it depends on where it occurs first in the brain. Keeping in mind, of course, that eventually it's global, all areas are affected. We've talked about how nurses can promote good brain health, looking at the risk factors for dementia. And also we've looked at noticing changes, what changes you might notice. And really it is about change. So what was different? How has the person changed? Could that be a cognitive reason? As opposed to, say, a pain reason or an arthritis, so that's why they can't use cutlery properly. It's something different to that. And that's sort of what this section will look at now. So I've just got a couple of little scenarios for you. So you find out there's been a change in social activities. So you have Max with you and you used to enjoy bowls and you're doing a care plan with him and you're like, you're talking about the bowls and he's like, oh, I don't do that anymore. And you want to know why. And a bit of a red flag is when people just sort of shrug and it's too hard to get there. Because often that means something. Why is it too hard? What's happened? And if we make the assumption that on face value that it's too hard to get there, often we'll think it's a transport issue. So we'll organise some transport, okay, because it's important to maintain your social connections. And it is important to maintain your social connections because research recently has come out of the UK, I think it was the UK, that social isolation takes the same number, and I might be putting it a bit simply here, takes the same number of years off your life as smoking 15 cigarettes a day, which I think's pretty amazing. But it is important to maintain your social connections. And it helps brain connectivity as well. So you see Max, but he hasn't gone. He hasn't used the transport. And so maybe, and this is what I mean, maybe there was a different reason and we hadn't asked. So maybe it's a loss of confidence, so it's short-term memory problem. Or maybe he's misnaming the jack and the bias. And he's been bowling for decades. So these are words he knows and he's embarrassed that he can't get the right word out. So that's a word finding problem or just a recognition problem, but aphasia. And so this information changes the strategy to support Max maintain his social connections. He doesn't need taxi vouchers or community transport. He needs a buddy, someone, whether it's a social support service or a friend, who can pick him up, go with him and offer him reassurance and support. So in this situation, you're going to be talking to Max about, has he got a trusted friend that goes as well? Has he got someone he can talk to about the fact he is getting embarrassed because he's getting words wrong or he's not remembering people's names? And often when you start couching it in a friendly, positive conversation, people will disclose this and you might be able to come up with strategies that work because you're actually addressing the problem. A similar one is you notice a change in personal care. This really used to be the point when you really used to notice this when men and women got dressed up to go to the doctor. So the men would wear their tie, their jacket, their suit, Sunday suit, and suddenly they turn up without their tie on. Or the woman would always have a beautiful brooch pinned to her jacket, and now it's not happening. So what's happening here? Are they down, lazy? Are they in pain? They can't be bothered. Or maybe it's become too complex. So it's that coordination part. It's executive planning, getting things in the right order. And so you want to gain different strategies.
Can I interrupt for a minute?
Yeah, go for it.
Another cue is that people wear the same clothes all the time. And I actually spoke to a podiatrist about this. I said to the podiatrist in our practice, do you have any role in dementia? Like, that's not really your concern. You look at feet, And she said, oh, hot socks. And I said, huh? And she said, they wear the same socks day in, day out. And they become damp and are very unhygienic and they're not good for the feet. So I think we need to be aware that if people are wearing the same clothes and you see them in the same clothes, maybe several times running, are they perhaps, wearing the same things repeatedly and not looking after themselves in that way? Because it's all too complicated.
And it's true. Because it's like grubby clothes. Is it a vision problem and they can't see it? Or is it a cognitive problem in that it's now a decision-making, getting changed, executive planning, type problem? So, and again, this is all fairly surface, but it's about that digging down because depending on what the actual problem is going to be a different strategy in order to, help the person maintain their independence. And with feet and podiatry, that one's interesting because in the next session, we talk more about comorbidity management in the context of cognitive impairment. And when you think about feet and diabetes, if someone's got diabetes and they've got foot ulcers, you've got cognitive problems that can impact on wound healing because of looking after the wound, but also that fact of poor foot care and wounds, again, is going to complicate it. So it's really important then to know if there's something cognitive underlying what's happening. So some of the ideas I've got here, if it's around complexity, is easy to get on and off clothes, like have simple fasteners, and it may be replacing, tiny little fasteners and buttons with clothes that have got bigger buttons or zips or something, whatever the person can manage. Shoes with laces, shoes with Velcro. You can get some good fitting ones now that don't look too hideous. Simplifying the environment. I've got what's called the Popple Rider test up there, which some people might recognise with the home care package assessments that used to be used for the dementia supplement. The reason I've got it up there is just mostly a prompt for me, but you sometimes hear people say, oh, they're really frustrated, the carer saying, oh, he's always asking me where his glasses are. They're right there in front of him on the table. but he's constantly asking me where they are, and it's driving me mad. And you find that there's a lot of clutter on the table and the glasses are sitting half under a newspaper. Someone with particular cognitive changes won't be able to make up the other half of the picture like we do. If we see a pair of glasses or something half covered, we can generally, our brain, without thinking, makes up the other half. And so we know what it is. But someone with a dementia with the damage in that area of the brain can't automatically make up the other half of the picture. So they might not see the object. So they won't be able to find their glasses or their toothbrush or something because it's hidden in their eyes. It's half under, not the full thing. So sometimes people with changes like that, or people with executive planning changes and sort of sequencing, sometimes having a clutter-free environment is really helpful because it gives prompts because you can see the items, you can set them up in the order in which they're used. And these are all things, like, we're not expecting you to problem solve all these things as a primary care general practice nurse, but they're useful to know because if the carer is really frustrated or the person's not managing, for example, if you think about having a shower, I've had it before, we tell them to go and have a shower and they just won't move. I come back half an hour later ready to go to the shops and they still haven't done anything. Think about how many steps are actually involved in having a shower. It's enormous. Think about the amount of planning, the decision-making, the ordering. It can be quite overwhelming. And so to take the stress out for the carer and also to support the person remaining independent in showering, I ask people to break it down into steps. Make sure that things can be seen that they need. Get them just to go and start the shower, then get them just to wash themselves first. Maybe put out a smaller selection of choice of clothing. Or if someone and you only put out one selection, put them in the order starting on the top of what you put on first. So there's all these little strategies that can help the person living at home, help the carer manage, the level of stress they must feel. If you can't support independence through those sorts of strategies, so in-house strategies, then maybe you do need to look at community care services like personal care, district nursing. I've sort of talked change to the environment. OTs are really useful if you can get hold of them, because they go in and do functional assessments and they've got a really good dementia knowledge on how you can change the environment or set up steps or aids differently, like memory aids, prompting, that sort of thing. I put a change in consonants in because that's really important, I think, consonants. A lot of people I talk to, consonants becomes the tipping point. When a person with dementia becomes incontinent, it's usually the time when the carer is thinking, I can't manage this anymore at home, and we're looking at residential care. So I think it's really important for us to be aware of what is it we're meaning by incontinence or continence. If someone says they're, wetting themselves or they're needing to change their clothes frequently or have their clothes changed for them, is it really a continence clinic referral for management? Or is it about the person knows they need to go to the toilet and they get there in time because they can find the toilet, but they can't undo the clothing? They can't process how to do it or they can't manage it. And so therefore they are so-called incontinent. I'm doing little doodads in the air with my fingers, but they're not actually incontinent. It's about managing the clothing adjustment. And it could also be about depth perception, colour differentiation or disorientation. And in these cases, signage saying where the toilet is or a picture of a toilet on the toilet door could be helpful to someone. And that can manage this perceived incontinence and keep someone at home longer and decreasing the carer burden or carer stress. Colour perception's another one, depth perception. You'll often find bathrooms are a series of white bowls. So you've got the bowl of the sink, you've got the bowl of the toilet and the bowl of the bath, perhaps, and they're usually always in a row. And if someone's having a problem with depth perception or colour differentiation, a bowl is a bowl. So I used to have someone that was peeing in the sink and actually destroyed the cabinetry around it. It was just cheap chipboard in a government managed facility, and they almost got kicked out, potentially becoming homeless. because they didn't recognise which bowl was for what. And so we put on different coloured, you can buy at Dementia Australia, for example, and other places, different coloured toilet rims, like toilet seats. And we put signage saying this is the toilet. So it helped for a little while, but things are always evolving and changing. So you have to stay on your toes. And there will come a time when things don't help, or we choose the wrong strategy and we've got to rethink it. I'll do one more because I'm appreciative of the time. So not eating well. So someone's losing weight. Is it a poor appetite, which could be attributable to all sorts of things? And weight loss, of course, we often want to rule out the more sinister around cancers or things like that, and the doctor will be managing that. But we can think more on a functional thing, that these person might not need a dietitian referral around good nutrition, but again, they might be having problems with cutlery, apraxia, all these visual perceptions and difficulties. The food looks too complex, it's too crowded on a plate, or it's on a coloured plate or a fussy plate. Again, when I used to work in the home, people often would put out the floral tablecloth, there'd then be floral crockery, and then a fairly complex meal. And it was just overwhelming for people. And so use white crockery, for example, with a coloured rim. Don't have it clashing and muddling with a tablecloth so people can find the plate, and maybe looking at finger food or simpler cutlery or bowls instead of plates, things that can help someone. Yeah, and simplify. I wasn't going to go into this section. We can pick it up later, but I can just quickly maybe touch on it. Shall I just keep going, Dimity?
Yeah.
So had you do this
fine.
section last time. I think I just wanted to stress here that the language we use, and this comes into the idea of stigma and it particularly comes into what we call changed behaviours, or you might know, BPSD, what is it, behaviour and psychological symptoms of dementia, where people can, and it's really difficult to describe without having a judgment on it and misinterpreting what it actually means, the changed behaviour. People are generally not resistive or difficult or aggressive. They're not wanderers. They're not sundowners. They're not absconders. And they're not empty shells, missing or dead, living dead. By using that language, we make it very difficult for ourselves to provide appropriate care and really understand the issues at hand. And we make it very difficult for us to understand, recognise, have empathy, and meet the unmet need of a person. Resistant one fits in sort of with what I was talking about. I didn't talk about showering and bathrooms, but if someone's got a depth perception change or a difference in the way they perceive objects, someone can become resistant to showers and be termed as difficult, and therefore you go into that person, say, when you're looking after them in hospital residential care, with a particular mindset of what this person's going to do. But if a bathroom uses a black mat, that could be perceived as a hole, so you're actually pushing someone into a hole to get into the shower. And some bathrooms, not so often now, used to have those little tiles, the black and white tiles, and that can be perceived as insects or moving or shifting ground. And so it's just interesting to think that they're not resistant to a shower, they're frightened, they're anxious. And so it's about us setting things up differently, talking to someone differently, supporting them differently. But I think this sort of idea is really important when we do talk about changed behaviours and thinking about what it could be. But we can pick more of this up in the next session with a case study and about how we can better support people around how the environment is presented to them, what does trigger anxiety in the person. The same as us. Very noisy electronic type music would make me incredibly resistive, aggressive, wandering, trying to escape, etc., because I really dislike it. And, so just it's kind of an almost normal response to a lot of behaviours. Of course, we have the range of dementia that impacts on people like the frontal lobe, which can make things quite extreme and present at-risk situations to people and others. But a lot of the time we can do something without labelling people as difficult, and make life easier and nicer for them as well as for ourselves as nursing staff. But as I said, we'll pick that sort of thing up. I'm not going to do that. I talked about that. But as we finish, I just want you to think about, with this body of information, what can you do differently in your practice within the environment setting you work in to improve the care you provide, or to better understand maybe where someone is coming from and how you might approach things differently? What might be a different question you ask? What might be a different solution to an issue you might come up with? And then this was the last thing about DTA wanted, the posting, and I think it's the same sort of questions. It's useful for us to get an understanding. I prefer the free text is the most useful part to us, for Dimity and myself, because it can give us some reflections on what you might have found was particularly useful. And I appreciate today was rushed because I started off on the back foot, and Dimity I haven't given as much opportunity to be involved because we normally will talk about issues a little bit more together. But was there any questions in the chat before we finish up? And please come along to the next session, because that's when you've got, if you reflect on this, you can ask more questions, and also we'll put some of it into more practice to sort of flesh out some of the concepts a little bit better. Thank you. Did you want to add anything, Dimity?
No, I think it's wonderful that we've still got so many people still here. It's fantastic. And
so come along
next
week.
That you came.
I'll try and have a camera.
Yes.
I can see you.
Hopefully next time, the tech will work. You never know.
Yeah.
And there was one query about at what age does dementia start, and I did actually respond, it can be any age.
Yeah.
Even young people can have it, but it's more common in older age groups, and I gave a couple of figures for that.
I wonder though, as comorbidities increase, chronic diseases because of lifestyle factors, etc., environmental factors, whether we might see it more early onset or younger onset, I should say, which is we term under 65. Is that right? Under 65?
Yeah.
Because we do see people in their 50s with dementia, usually frontotemporal.
Yeah.
Particular issues because they're often still working, providing an income to the family, younger children.
It's very stressful.
And it's a very different approach and challenges. One thing I will say, under here, I have a massive list of resources for you. Knowing your local formal and informal support networks, resources for all sorts of things, risk reduction, education, First Nations, cold, change behaviours, advanced care planning, further education, the best ones, I think. So there's lots there, and they'll be at the end that you can tap into if you want to explore different little bits.
And there's some nice comments in the chat. Very thorough and detailed. Thank you, Caroline.
Thank you.
And someone else said thank you. So, and also Phoebe has asked for you to please also complete the evaluation for the PHN, which is separate from this one that you're doing with your QR.
I know they can be a nuisance. I know myself when I go to webinars, it's so easy to think, oh, I want to go and have lunch now, or I've got 5 minutes before I get back to work. But they are useful for us. We ask the questions for a reason. Well, we try to. That's why I like the open-ended one. And they will help us improve, because it's a fairly new area, and particularly with us teaching practice nurses and primary care nurses, and it's useful to make sure we're addressing what it is you need. So let us know if we're missing something, etc. But come next week and you can see the lot.
Yay.
Thank you.
All right. Phoebe, we hand over to you now.
Yes, thank you, team. I just want to thank our wonderful presenters, tech issues and all. Really, really well thought out presentation, and really useful interactive walk away aspects. So thank you for that. Thank you to everyone who joined today for spending your lunch with us, an extra long lunch, but your lunch with us. And please take Carolyn and Dimity up on their request for you to come next week, because obviously part 1 was amazing. So I feel like part 2 is just going to be amazing as well. But that's it for today. Thank you so much and look after yourselves.
Thank you all. See you next week.
Thanks, Phoebe. And maybe
Thank you.
Carolyn and I will just stay online for a sec to debrief
Yeah,
with you about
we
the
can do that.
tech, Phoebe.